Hello and welcome to Chronic Pain Tips for Patients. I'm Dr. Yuri Martins. I'm a chronic pain physician in the St. Louis and Southern Illinois areas, and in this episode, we are going to talk about something many patients ask about: sauna, hot baths, infrared heat, and other heat-based therapies for chronic pain. Heat is familiar. Most people have used a heating pad, a warm shower, a hot bath, or hot tub when their muscles were sore. It feels comforting, it feels natural, and for many patients with chronic pain, the idea of using heat instead of another medication is very appealing. The real question is, can sauna or hyperthermia therapy actually help chronic pain? The honest answer is sometimes, for some patients, and usually as an adjunctive treatment. That means heat therapy may help some people feel better, move better, or participate more effectively in rehabilitation. But it's not a cure, and it should not be marketed as a replacement for a comprehensive pain treatment plan. In this episode, I will explain what sauna and hyperthermia therapies are, why heat may reduce pain, which chronic pain conditions have the strongest evidence, and how patients can think about safety. So, what do we mean by heat therapy? When people hear the word heat therapy, they may think about many different things. Some people think about a traditional sauna, others think about infrared sauna, others think about hot tubs, warm baths, mineral water spas, heating pads, or medical devices that heat the whole body or a specific painful area. These therapies are related, but they are not the same. A traditional Finnish sauna usually uses very hot dry air, often around 176 to 212 degrees Fahrenheit. Sessions are usually short because the heat stress can be intense. As far infrared sauna uses infrared radiation to warm the body at lower air temperatures, often around 122 to 140 degrees Fahrenheit. Some patients tolerate this much better than a very hot traditional Finnish sauna. There's also something called warm therapy, a Japanese style infrared sauna protocol. It usually involves a sauna at around 140 degrees Fahrenheit for about 15 minutes, followed by a resting period under blankets to maintain warmth. Then we have balneotherapy, which refers to therapeutic bathing, often in mineral or thermal water. Hydrotherapy refers more broadly to therapeutic use of water, including warm water immersion and aquatic exercise. Whole body hyperthermia is usually more medicalized. Some devices are designed to raise the body's core temperature in a controlled way, often to a mild fever-like range. And finally, localized hyperthermia applies heat to a specific area such as the knee, low back, or painful muscles. So, why does this distinction matter? Because a 20-minute sauna session at a gym, a hot bath at home, a mineral water spa program, and a medical whole body hyperthermia device do not deliver the same heat dose to the body. They may feel similar, but biologically they can be very different. This is one of the most important points in this episode. Not all heat therapy is the same. Heat can affect pain through several mechanisms. First, heat increases blood flow. When tissues are warmed, blood vessels dilate. This can improve circulation, reduce stiffness, and make movement feel easier. Second, heat can relax muscles. Many patients with chronic pain develop muscle gording. The painful area becomes tense, and that tension can amplify the pain. Heat may reduce these protective spasms. Third, heat can influence the nervous system. Warmth activates temperature-sensitive receptors in the skin and deeper tissues. These signals can interact with pain processing pathways and may temporarily reduce pain perception. Fourth, repeated heat exposure may affect inflammation and stress physiology. Some studies suggest that heat may influence inflammatory mediators, autonomic nervous system's activity, and heat shock proteins. But I want to be careful here. These biological effects are interesting, but they do not mean that heat can treat every cause of chronic pain. For me, one of the most practical benefits of heat is that it can help people move. If heat reduces stiffness enough for a patient to walk, stretch, exercise, or sleep better, then heat may indirectly support recovery and function. That is usually how I think about heat clinically. Heat is not a standalone solution, but it can sometimes open a window that allows better movement and better rehabilitation. So, where is the evidence strongest? Now, let's talk about the evidence by condition, okay? The first condition is fibromyalgia. Fibromyalgia is probably the chronic pain condition with the strongest evidence of response to heat. Studies of hydrotherapy, balneotherapy, and whole body hyperthermia suggest that some patients with fibromyalgia may experience reduction in pain and improvements in quality of life. Some studies of water filtered infrared, a whole body hyperthermia. I know it's a long, very long term. So this whole body hyperthermia device have also shown improvements in fibromyalgia pain that lasted beyond the treatment period. That phrase is a mouthful, so let me explain it. Water-filtered infrared, a whole body hyperthermia, is a medically supervised form of heat therapy. It uses filtered infrared light to raise the body's core temperature in a controlled way, similar to a mild fever. The water filter removes wavelengths that would excessively heat the skin, allowing deeper and better tolerated warming of the body. This is different from a regular sauna, okay? It's a more controlled medical therapy and should be supervised by a physician. Why might this be relevant for fibromyalgia then? Fibromyalgia is not simply a problem of one joint, one disc, or one nerve. It is a condition of widespread pain sensitivity. It is often associated with fatigue, poor sleep, cognitive symptoms, and increased nervous system reactivity. For this reason, treatments that influence whole body temperature regulation, autonomic tone, sleep, mood, and pain processing may be particularly relevant. However, patient needs to keep expectations realistic. Heat therapy is an adjunct. It does not replace exercise, sleep optimization, mental health support, pacing, medications when appropriate, and treatment of coexisting conditions. Some patients with fibromyalgia feel much better with heat. Others may feel worse if the heat exposure is too intense. Too much heat can trigger fatigue, dizziness, headache, or next day worsening. So again, the dose matters. In many studies, heat sessions are applied 2 to 3 times per week for about 15 to 30 minutes, depending on the protocol. The second condition where heat may help is knee osteoarthritis. Knee osteoarthritis pain is often associated with joint stiffness, reduced mobility, muscle weakness, and inflammation around the joint. Localized hyperthermia and thermal water therapies have shown benefit in some studies, including improvements in pain, stiffness, walking ability, and daily function. This makes sense clinically. Heat can make a stiff joint feel more mobile. It can relax surrounding muscles. It can help the patient participate more comfortably in strengthening and mobility exercises, but we should not view heat as the main treatment for knee osteoarthritis. The foundation remains exercise therapy, weight management, physical therapy, appropriate medications, injections in selected patients, and sometimes surgery when conservative care fails. Heat may help symptoms, but it does not rebuild cartilage. In practical terms, for knee osteoarthritis, superficial heat is commonly applied with hot packs or heating pads for about 20 to 30 minutes per session, often once or twice daily over several weeks. More formal localized hyperthermia has also been studied using microwave diathermy applied directly to the knee for 30 minutes, 3 times per week for 4 weeks. In one study, this was associated with improvements in pain, stiffness, daily function, and walking performance, lasting up to 16 weeks. One practical tip is that heat may be especially useful before exercise. If heat reduces stiffness and discomfort, patients may be able to participate more effectively in quadriceps strengthening and other rehabilitation exercises. But patients should avoid excessive heat, protect the skin from burns, and remember that localized heat is better used as an adjunct to standard osteoarthritis care. Now, let's discuss chronic low back pain. Here, the evidence is more mixed. Some thermal water and spa-based studies suggest benefit, but many of these programs include multiple treatments at once: warm water, exercise, relaxation, time away from work, supervised therapy, and the therapeutic environment itself. That makes it difficult to know how much of the improvement came from heat alone. That makes it difficult to know how much of the improvement came from heat alone. Whole body hyperthermia has also been studied in chronic low back pain, but the benefit appears modest. In practical terms, heat may help some patients feel better temporarily. It may reduce muscle tension and improve participation in rehabilitation. That is valuable, but it should not be oversold. For patients with chronic low back pain, the long-term plan should still focus on identifying pain generators when possible, improving function, addressing fear of movement, strengthening, sleep, ergonomics, mood, and other contributors. Heat can be part of the plan, but it should not be the whole plan. For pain caused by inflammatory rheumatic diseases, such as rheumatoid arthritis and ankylosing spondylitis, some spa and hydrotherapy programs have shown improvements in pain and function. However, these programs usually combine heat with exercise, physical therapy, and other interventions. That means we cannot easily say that sauna itself is the active ingredient. Patients with inflammatory arthritis should also be careful not to confuse symptom relief with disease control. Heat may reduce stiffness and discomfort, but it does not replace disease-modifying medications prescribed by a rheumatologist. If inflammation is active, the priority is controlling the disease process. What about neuropathic pain? For neuropathic pain, the evidence is very weak. Neuropathic pain includes conditions such as diabetic neuropathy, postherpetic neuralgia, nerve injury pain, radiculopathy, and some forms of burning, shooting, electric, or tingling pain. Currently, there is no strong controlled evidence that sauna or whole body hyperthermia reliably treats neuropathic pain. Some patients may feel temporary comfort from warmth, but others may be at risk because neuropathy can reduce temperature sensation. If a patient cannot accurately feel heat, burns become a real concern. This is especially important for patients with diabetic neuropathy. So hot tubs, heating pads, and very warm water can injure the skin if sensation is impaired. In my practice, I generally advise patients with peripheral neuropathy or impaired sensation to avoid heat or cold therapy unless specifically cleared and instructed by their physician. Now we need to talk about an important concept too. One of the biggest mistakes in wellness marketing is taking a medical study of one heat protocol and applying it to every sauna product. For example, some studies use controlled whole body hyperthermia devices that monitor temperature and deliver a specific thermal dose. Other studies use mineral baths at controlled temperatures. Others use localized microwave hyperthermia applied to a specific joint. That is not the same as saying any sauna will treat chronic pain. The body's response depends on many factors: temperature, duration, humidity, hydration, body size, cardiovascular health, medications, heat tolerance, and whether the person rests afterwards. A short sauna session and a structured clinical hyperthermia protocol may feel related, but they are not interchangeable. Patients should be cautious when they see very strong claims online, such as sauna cures chronic pain, infrared sauna detoxifies inflammation, heat therapy reverses nerve damage, sauna replaces plain medications. These statements go beyond the evidence. A more accurate statement would be this: structure heat therapy may help some patients with chronic pain, especially fibromyalgia and knee osteoarthritis, when used safely as part of a broader treatment plan. So, how can patients try heat therapy more safely? For patients who tolerate heat well and do not have medical contraindications, a cautious approach is reasonable. Start low and slow. Do not begin with extreme heat or long sessions. A brief exposure is safer than trying to push through discomfort. Hydrate before and after. Heat exposure can cause sweating, dehydration, and lightheadedness. Avoid alcohol. Alcohol and sauna are a dangerous combination because both can lower body pressure and impair judgment. Do not use sauna when you are acutely ill, feverish, dehydrated, or feeling faint. Stop immediately if you develop chest pain, shortness of breath, severe dizziness, confusion, palpitations, or weakness. Be careful when standing up. Heat can lower blood pressure and increase the risk of fainting, especially when leaving the sauna or a hot bath. Avoid sleep. Avoid sleeping with heating pads. This can cause burns. Do not apply intense heat over areas with poor sensation. Patients with diabetic neuropathy, spinal cord injury, significant vascular disease, or impaired temperature sensation should be particularly careful. So, who should talk to a physician first? Patients should speak with a physician before using sauna, hot tubs, or whole body hyperthermia if they have unstable heart disease, a recent heart attack, severe aortic stenosis, uncontrolled blood pressure, frequent fainting, severe dizziness, significant autonomic dysfunction, advanced kidney disease, fluid restrictions, pregnancy, heat intolerance, neuropathy with reduced sensation, open wounds, active skin infection, severe dehydration risk, or complex medical conditions. This long list means just one thing. If you're going to start a heat-related protocol for chronic pain or other medical condition, speak with a physician first. Patients taking medications that affect blood pressure should also be cautious. This does not mean that every patient in these categories can never use heat. It means the decision should be individualized. So what should patients realistically expect? When heat helps, patients often describe benefits such as less stiffness, less muscle tension, temporary pain reduction, improved relaxation, better sleep, and easier movement after the session. These are meaningful outcomes for chronic pain patients, but patients should not expect heat therapy to permanently eliminate structural pain generators, such as severe spinal stenosis, advanced arthritis, unstable joints, or nerve compression. Heat may improve symptoms, but it does not necessarily fix the underlying anatomy. A good test is functional. After heat therapy, can you move better? Can you walk more? Can you strengthen more comfortably? Can you sleep better? Can you participate more effectively in your rehabilitation program? If the answer is yes, heat may be a useful tool. If the answer is no, or if symptoms worsen afterwards, it may not be the right therapy for you. So, what is the bottom line? Sauna and other hyperthermia therapies may be used as an adjunctive therapies to provide pain relief in some patients, but they should be discussed honestly. The stronger evidence is for structured heat-based therapies, especially warm water therapies, balneotherapy, and supervised hyperthermia protocols in selected conditions. Fibromyalgia appears to be the most supported chronic pain condition. Knee osteoarthritis, knee osteoarthritis also has encouraging evidence. Chronic low back pain may improve in some patients, but the effect is usually modest and should be combined with active rehabilitation. For neuropathic pain, the evidence is currently very weak, and there may be safety concerns if the patient has reduced temperature sensation. Heat therapy can be helpful. It can reduce stiffness, relax muscles, improve comfort, and help some patients move better. But heat is also a physiological stress. It is not just a wellness luxury. For the right patient at the right dose, heat can be part of a thoughtful chronic pain plan. For the wrong patient or at the wrong dose, it can cause dizziness, dehydration, worsening symptoms, and injury. As with many chronic pain treatments, the key question is not simply whether sauna is good or bad. The better question is this safe for this patient, for this condition, at this dose, as part of this broader treatment plan? That is why individualized chronic pain care matters. If you're living with chronic pain and wondering whether sauna, hot baths, infrared heat, injections, medications, physical therapy, or other treatments might be appropriate for you, consider discussing your symptoms with a pain specialist. You can also visit my website for more chronic pain tips at www.ycmartins.com. You may also contact my clinic to schedule an appointment. Chronic pain is complex, but it's treatable. The best plan is usually the one designed around your specific diagnosis, goals, and medical history. Thank you for listening to Chronic Pain Tips for Patients. If you like this content, please follow us on Spotify or any other podcast player and leave a comment. This podcast is for educational purposes only and should not be as a substitute for direct medical advice from your doctor or another qualified healthcare provider. Any views, thoughts, and opinions expressed in this episode are solely those of the speaker and do not necessarily reflect the views, opinions, policies, or positions of the speaker's employer, company, institutions, or other associated parties.